Hello everyone. I welcome you all to the live lecture series organized by Jan Swasthya. This is the third day of our lecture. Yesterday, due to some technical errors, the interaction didn't take place as was planned. Today, we hope not to have such disruptions. Jan Swasthya as an organization believes in seeking solutions together to overcome crisis, and to make this possible, we have arranged a series of talks by experts on different issues related to the corona crisis. I welcome you all to the live lecture organized by Today's topic is battle against corona and challenges faced by health workforce. Even when our healthcare workers, doctors, nurses, and also other staffs, including sanitation workers, are putting their lives at risk to save ours, are we doing enough to take care of their concerns? We repeatedly hear stories of healthcare workers brutally attacked at different places in the country. Also, is the government taking the responsibility to provide healthcare workers with proper personal protection equipments and other safety gears to carry out their duty in a safe environment? These questions loom large in each of our minds. Jan Swasthya as an organization has tried to intervene in various ways possible to make demands on behalf of our healthcare workers to central and state health ministries, especially for our nurses. We are proud of the fact that we have a large number of nurses as our members of the organization, and we stand in solidarity with all those who are in the healthcare sector. Today, we have one of the experts in this field, Susanna Barria, to talk to us on this topic. She works with Public Service International and is also a member of Jan Swasthya Abhiyan's working group on COVID and health workforce. She is also part of ASHA. With these words, I would now invite Susanna Barria to share her views with her. Please, ma'am.
Hi, good evening. It's really a pleasure to be here. Can you hear me well?
Yeah.
Okay. So this is a great opportunity to speak about the issues that are faced by health workers in the context of the COVID-19 pandemic. And the first thing I would like to do is to set the context. But I think you already had a few discussions that looked at what the issues of the health systems are. So I wanted to concentrate on the situation of healthcare workers within the health system and map the situation before the crisis, so that way we can better understand how and why the health workforce is facing a very challenging situation today. And so first looking at, for instance, at public facilities, where you know that there's been a continuous underfunding. And the way that has affected health workers is that, for instance, there is a massive level of vacancies of health professionals, from doctors to nurses to paramedics. And that means that there is a very heavy workload on the existing staff. And that was already hard to manage before the crisis came in. In many facilities, and especially in facilities that are working on the local bodies or in poorer state governments, that shortage of professional staff has been dealt with hiring on short-term contracts. So for instance, that's the case for nurses, for paramedics, and in some cases also we even see that field staff are deployed in hospital settings. So for instance, A&Ms will be brought to work inside a hospital, but still at the kind of pay that the A&Ms are given to do the usual work. And on the other hand, what are called health workers, which are considered as non-professional, ward attendants, ambulance workers, housekeeping staff, cleaning, security, these are mostly now outsourced, contracted through manpower agencies. And that means that they have low wages, pathetic working conditions, and very often that is the working conditions are very much in violation of the law. So this is kind of one area where you have a lot of informalized workers. And a second one is in the private sector, because while the private sector has thrived, expanded, we know it is under-regulated, and that means even working conditions in private sector are not regulated properly. So except for some highly specialized doctors, the workforce in private facilities is highly underpaid. And you would have seen in Delhi, there was a protest at the end of last year. Nurses in private hospital were saying that there has been a Supreme Court recommendation, there has been a Delhi High Court order to increase their wages, increase all the wages in private hospitals, yet that has not happened. And nurses are paid around the minimum wage, but also below that legal benchmark. And that sets the scale for the other staff who also pay, I mean, the other staff that come below them. And that also means, and that is then added to the fact that you have also hiring through third-party agencies, and again, highly insecure tenure of work, and no social security coverage. And then a third element or pool of this very informalized health workforce is at the primary level of care. Health post community level are very neglected. And we've spoken a lot about the ASHAs in rural settings. And then in city settings, you also have in cities like Mumbai, you also have community health volunteers, which are doing the same work. And these are the largest group of health workers. There are more than 9 lakh, mostly women, who are denied their status as workers, denied minimum wage, and any other rights that workers have under the law. So as now health workers across the health system have been mobilized to respond to the COVID-19 pandemic, these pre-existing cracks and weaknesses in the system make it even more fragile. And this informal employment that leads to unclear responsibility towards workers creates blind spots in the system, and that is coming out very starkly now. So with the COVID crisis, the first point I want to make is that considering the population of India, we are not in a situation where facilities are facing an avalanche of cases. Yet, the health system is already stretched in places where cases have come up. And already the health workforce is facing a big challenge. One of them is what you mentioned also in the introduction. It's the question of access to personal protective equipment. That's been a bit all over the news. And what the government is trying to say is that there isn't much it can do because the issue is with the availability. But that's actually not the full story, of course. Because in many states, what you see is that basic safeguards and equipment such as sanitizers, gloves, simple basic masks, these have been denied to health workers, despite that they're available on the market. So for instance, when ASHAs are asked to go and trace cases, or in Punjab or in Haryana, this has come up, or community health volunteers in Mumbai also having to trace cases, contractual employees in the Hyderabad Municipal Corporation has also raised this. All of these have been told that they are not going to be given, and it's not a question of the fact that they are not on the market. With more specialized personal protective equipment, N95, face shields, bodysuits, there is a question of shortage. But even what is available has not been distributed equally. So for instance, typically doctors would be given priority compared to nurses, despite that in the actual facts, the nurses are the ones who have to go closer to the patient and get into a level of contact where they are more at risk. And the provision efficient in public facilities and in the private sector, some nurses are just told to work without it. And I think it's quite clear that employers to a certain extent are also emboldened to respond in that way because they don't have to bear the direct responsibility to provide social security and other support in case those workers get affected. So they are not bound to pay for healthcare in the case of, for instance, the private sector, despite that they have when they were especially, there was so much attention from the media. But they're not bound to. They are not bound to pay sick leave or quarantine leave. In the case of ASHAs or contractual workers, if they are on sick leave or quarantine, there is no provision for them to be paid during the period. And there is no provision for any compensation, despite that, them getting sick would be equivalent to acquiring a disease during work, and there should be a compensation for that. There is no systematic tracking of the number of health workers that have been infected by COVID-19 in India. Some reports are saying they're close to 100 that have come positive, but this is most probably an underestimate. And one problem is that even for health workers, there isn't enough testing. And asymptomatic health workforce, for instance, are not tested. And these, all these issues put health workers at risk and the larger public at risk. This is really one key issue. The second issue I wanted to highlight is that health workers are really working in a very challenging environment today. There has not been adequate training, and therefore there is a certain level of lack of clarity on procedure. Across the board, we see that from ambulance drivers to security guard in hospitals to, of course, nurses that are taking care of patients or doing the screening. And because of that, there is a tremendous stress. Of course, people are scared to get infected, and they're also very scared to infect their dear ones. And you would have heard that recently one 2-year-old child of a nurse came positive for COVID. So added to this level of stress and a certain level of uncertainty, there is also a problem of facing a very hostile environment in a range of situations. You see it from where people live. Health workers have been asked to leave from their rented accommodation in several cities. You see reactions from the people that they are supposed to take care of in the community and in the hospitals. ASHAs have faced verbal abuse and physical violence in some cases when they are going either for COVID-related work or for their routine tasks. Health workers have been gagged and scolded when they speak up on issues at the workplace. In Delhi, nurses treating COVID patients were put in substandard hospitals while doctors were accommodated in the Lalit hotel, and that's plainly discriminatory. So you have many of these situations that make it very challenging. And what we're hearing from some, for instance, of the nurses working in the private sector is that if connectivity is established, they might just go back home because there is just too much adversity around them. And that's the case, for instance, from nurses from Kerala. A third element I want to highlight is the question of security of tenure and wages. And the government has paid lip service to informal workers. Despite saying that, there should be measures taken, there is no system to actually work on it. So we have already been seeing that contractual, mostly ancillary health workers or cleaning staff, for instance, have been dismissed by contractors. They are not considered on duty if they are not able to join work. In the state and the central government, you can still see how ASHAs are very much taken for granted. The central government has formalized their role, which is quite central in terms of containment and community outreach, but it hasn't given up an additional budgetary allocation for that additional work. There is a paltry 1,000 rupees per month that has been announced, but it needs to be used from unspent money. So they still need to take care of antenatal care, vaccination, their routine work, and on top of that do this COVID work. So it makes clear that they are really an essential workforce, but still that recognition in terms of ensuring the wages are not has not been stated. And in private hospitals, workers were told last month that their salaries were going to be cut for contribution to the PM Care Fund. Mostly the interest in doing that vanished when the government clarified that such contribution will not be considered as CSR. This month, again, health workers in private facilities are hearing that their salary might be cut next month because there are not enough patients coming in. So that question of having a wage is an issue across the board, and it's a different depth, but it is really something that is everywhere. The fourth issue I wanted to highlight is, and that's something we also repetitively hear from unions, is that private facilities are not following existing government protocols. They are indulging in negligence, and of course that is having repercussions for the workers. We know that, for instance, nurses when told that if they're not ready to work without PPE, then they can just leave the job. Linked to that, we saw that in hospitals in Delhi and in Mumbai, private hospitals became hubs of the spread of the virus. not only in private hospitals, but more. And in those cases, unions raised very clearly that there was a question of negligence by the administration because it failed to follow protocols. Especially, it doesn't want to take precautionary steps because it has a cost. And the government has no system in place to track that and to address these issues. So this is putting, of course, the public at risk, not only the health workers, but really all of us at risk. And finally, I think one issue that we need to also be very worried about is the question of the quantity of work. I mean, we already know that most professional health workforce, most professional health workers were facing a very intense work condition, like really at the upper limit of what it can be. For instance, nurses to patient ratios in public hospitals are between 3 and 5 times more than national and international norms. Now, under the excuse that there is less patients, then there is an extension of the work time. So to intensification, I mean, you had a situation where it was very intense because that intensification is supposedly not there. Now you extend the working hours. And the challenge is really going to be that the moment that the lockdown is lifted and possibility of more patients coming to the hospitals because normal life starts again, in addition to the fact that COVID will still be around, and therefore you have that both burdens at the same time. If you see that combination of that work intensity and that extension of working hours, most chances are that workers will get exhausted very fast, and that increases the risk of infection, which is another way that hospitals can become a hub of infection, putting health workers, patients, the broader public at risk. I think I'm going to close now so that we can have more discussion. And just to conclude, to say that this crisis really has exacerbated existing inequalities, made them much more visible, brought attention to the cracks in the system. And as there is attention given to health workers, but also a recognition of the importance of quality public health systems in responding to crisis, in being there for people, in being the reliable kind of ways that that health can be ensured for all. This is really an opportunity to push for long-term solutions, because many of these are long-standing issues, and I hope we can, and I'm sure we can all work together towards that. Thanks. So I think there are some questions that already came in. The first one, are we really prepared or equipped with sufficient PPEs? No, we're not. We're nowhere ready. There are problems with the amount of PPEs that were available on the market, the amount of PPEs that can be manufactured in the country, and the amount of PPEs that the government has even bought for its workforce. And there are problems at all these levels, because somehow, you know, the issue is also that when in that came clear when the government made an announcement for all health workers will get security coverage. The government wanted to provide, you know, insurance for accident to all health workers, and it said therefore it will be there for 22 lakh workers. And that's a huge underestimate of the actual health workforce spent. And because the government doesn't have a real understanding of the size of the health workforce, because there are all these spaces where it loses the count. It doesn't always count in the ASHAs and scheme workers, but it also has lost count of the amount of people who are on contract. And there are these blind spots where even if the government was kind of trying to do its numbers right, it doesn't have the data about where the health workers who are there. So that will make the situation complicated all the way till the end, and will have to be really monitored closely all the moment to, you know, the moment that the PPAs are putting in the hands of health workers. The next question, are we even now talking about doctors, nurses, paramedics, but not much about the lower level medical force. Yes, that's true. I mean, it's also that there is less information coming out. We know that there are issues with losses of jobs. People were not able even to reach certain hospitals because at the moment that the lockdown started, suddenly there was no public transport. So for cleaning staff, for instance, to make it to the hospital, there was just no transport available. And again, because most of the cleaning staff will be contractualized, that responsibility of the contractor ensuring that those workers were coming to the hospital for their jobs was, there is no commitment there. So just find somebody else who can come and ensure that whatever minimum level of the job that needs to get done, gets done. So we know that there is a real issue there in terms of losses of wages, of people actually being part of those that need relief to be able to have their like 3 square meals a day. But I think it's also that one, of course, we always talk first about doctors. There's been quite a bit of attention with nurses, and PPEs has been a very kind of, it's captured the imagination. And with a lot of the staff, security staff, house cleaning, housekeeping, the PPE issue is not at the same level. So even the entry points from where the attention has come in have not been issues that are most fundamental for the lower level medical health force. So that's something that we need to work on and ensure that we're able to put forward those issues much better. Medical staff.
So can I come in here with can I come in here with one question, Susanna, because it is related to this specific question. One is you told about the lower level of healthcare workers are facing a lot of challenges, but there are two specific categories that I would like to seek your discussion. One is about the sanitation workers in the hospital. What are the key things that they are facing, and in terms of waste management and the possible infection that they are, and what kind of protection the planning has already been done, whether it is from the Pollution Control Board or from the Ministry of Health and Family Welfare, whether it is adequate or not. That is one question. Second is about the mortuary workers, because the mortality is now going up. And in addition to the doctors and assistants in the mortuary, the postmortems are assisted by the mortuary workers, and then the dead bodies are handled by the mortuary workers. So how you see these two categories, because they are not always counted as healthcare workforce, but they provide a major role in the healthcare support system. How would you see this?
Okay, so starting with the mortuary workers, my understanding is, and I depend on the WHO's guidelines really to myself up to things, because there is no understood transmission through the dead bodies. There is an understanding that mortuary workers don't need specific personal protective equipment. Dead bodies. Except if they were to go into the hospitals and be in the environment where the COVID is there, because you have other patients. But from the moment that they receive the body and then take care of it, my understanding is that, for instance, they don't need any specific additional PPE. I mean, there is the working conditions that they should always have, but COVID doesn't add to that. So because of that, it kind of falls a bit between the cracks. And that's also the danger, right? Is that there is attention on COVID now, so anything that is a COVID-related issue is an issue. If people just have issues, then let them have issues. They were having issues before. With sanitation workers, there is a bit of a similar situation too, in terms of the attention that is given to them. Sanitation workers in the cities are handled by either the state government or the municipality. And the question of them having access to gloves and masks has been on the cards. And I think what is interesting is that there was a certain reluctance also of workers to use it, because it's kind of doesn't allow you to work properly. It's kind of on your way. And what we hear from unions is that with COVID, those that had access to masks and gloves are using them, and those who don't have access are asking for them. in a situation where it wasn't something where the workers themselves were having a very strong demand for it. In terms of the sanitation workers in public hospitals, so there is that situation that is, I think, very strongly linked to contractualization. So as I was saying, the situation where people were not finding any transport, so therefore could not go to work, and therefore were either fired or not given their income. In some cases where they were pending wages for the last 2-3 months, that were stories of sanitation workers in the city of Delhi. Then you have sanitation workers that are directly under the government, where the issue would be in terms of, or that are, directly employed by the hospital, even if they're on short contract. There, the situation would be also a question of the fight for protective equipment. And for instance, that has been a problem for a very long time. One of the issues that we had raised a few years ago was that in the TB hospital, the Sevri TB hospital in Mumbai, sanitation workers were not provided protective equipment. In a situation where it is very clear that you are at high risk of being infected because of the way TB transmits, it's actually a much higher risk than the risk that is associated to COVID. So that's a very long-standing issue, and it's probably an issue that is still ongoing because they are not enough. The government or the facilities are not forthcoming in providing this, and again, in the line of priorities, they would be among the last ones.
So thanks. So the next question is about, some of the health workers are, whenever they are positive, they are forced to share rooms, bathrooms and all that. Even in Delhi, we are hearing that kind of reports. The second added question that come here is that, some in private hospitals, specifically in terms of for saving the PPE stocks, what they are doing is, they are extending the shifts of doctors, nurses and various other people. So from the 8-hour shift, sometimes, they are even asked for doing more than 3 shifts or 4 shifts continuously. So that kind of situation is also there. So how would you see that? How are we, our managements, whether it is private, whether it is public, are dealing with the healthcare workers? What kind of, is it a sympathetic or empathetic approach, or is it an apathy? That is something to be looked at. If at all, if it an apathy, how to change it? That question is very important. And added to this particular, thing is that whether nationalization of healthcare facilities is an option, private healthcare facilities is an option for addressing this particular problem.
So regarding the question of sharing of bathrooms, really what we heard from the nurses that we work with, and the stories come mostly from Delhi, the problem was that, okay, so you have a hospital that is designed as a COVID hospital. And of course, you need to ensure that the health workers that are in close contact with patients and are at a high risk stay close by, because you don't want them to move in the city. We're talking about doctors and nurses mostly. And that's when that story of doctors are put in the Lalit, and then, oh, let's find something for the nurses. And they found a hostel where you had this situation of not only shared bathrooms, but also quite inadequate facilities. In other cases, for instance, there were not even mattresses, and they had to set up the place. So the problem with that is that when you are coming back from your shift, all of you will be finishing your shift at the same time, and you don't want to take a risk to infect your colleagues, or you want to be sure that you can move around properly, and you don't need to have on your mind that you might be infectious. So you have to get into the bathroom, wash yourself, wash your clothes. And to be able to do that, it takes some time. So when you have a shared bathroom, one, you have an increased risk that the bathroom itself can become a place where infection gets spread among more people if it's shared about a large amount of people. But it also creates a situation where you come back home and actually you haven't finished your day. You need to wait so that everyone does that process. And you already had a day that is not been an 8-hour shift, but it's been a 10 or 12-hour shift. So it just becomes extremely exhausting. The related question with PPEs is that when you speak about the PPEs, the full system of the bodysuit and the mask, the face shield, and the N95 and the gloves, it's actually quite heavy. So you are not supposed to re-wear it. So if you go to the bathroom for a break, you're not supposed to wear that same PPE again. Otherwise, there is a problem of possibility of reinfection. In South Korea, they had decreased the shift's length to 2-3 hours because of that. In India, we are told that people have to do a full shift of 12 hours, which either means that you cannot go to the loo for 12 hours, or means that you use it and you reuse it, which means that you're kind of breaking protocols of infection risk. So what I understand is that generally you are given more than one PPE for a shift of 12 hours, but then it really depends. And the kind of working conditions and the kind of care that will be taken of those issues is very different from one hospital to the other. So it will be also very different for doctors and for nurses. For instance, in the case of doctors, you've heard of 3-4 shifts continuously. In the case of nurses, it's just impossible. Just can't do it. So I don't think they have even been those situations, because already one full shift is extremely tiring, because this is too heavy, and the kind of work you do means that you are in a much more active kind of situation. So is there apathy? I think in the private sector there is a tendency to be a case of negligence, not only apathy but really just negligence. And in the public sector it's a mixed bag. You have situations of apathy, you have situations of trying to deal with, but at least you have a certain amount of dialogue that is going on with the state government that puts pressure on hospitals to behave and be part of a certain way of doing things. Interestingly, I think the media is playing quite an important role. It's unusual, I feel, for India to have the media taking up what are actual issues in such a way, and in many ways also even contributing to issues of informalized health workers to come to the fore. That is also, I think, playing a very strong role in the kind of dynamics that we're seeing. The question of nationalization, this is something that even nurses in private sector have been saying. We want the government to ensure that if there is a problem, we have a number that we can call and say, these hospital procedures are not followed, protocols are not followed. If hospitals don't, change their behavior to follow protocols in a much better way, then there should be a takeover for sure. Because otherwise you are creating these situations where you allow for, possibilities of more hubs of infection to be created, and everyone is going to have to deal with that. The government will also have to deal with that. So it has to take very strong steps to avoid those situations. Yeah. You're on mute, Ram.
One question that has come is about handling of vegetables, fruits and currency notes, which is a general question not related to the health workforce. But I have two more questions here about the health workforce, because one of the things, while in the shifts parts, what we are doing is we are extending the shifts, but in terms of the quarantine protocol, even if that healthcare worker, whether it is a doctor, whether it is a nurse, whether it is a ward boy, whosoever, is coming in contact with a positive person, even for a very short while, passing through that room and all that, the quarantine protocol currently suggests that they need to go for a quarantine for 14 days. But in Singapore, it is 30 minutes time if they have spent without the patient having mask or covering equipments continuously within a 1 meter kind of distance, or less than 1 meter kind of a distance. In other places, generally it is 15 minutes in that kind of a. But in India, we are doing it even for a minute. So is such a quarantine protocol helping the health workforce, or the other way around?
So that's also a discussion we had about the personal protective equipment, where interestingly the government guidelines, Government of India guidelines, are more demanding than the WHO rational use of protective equipment guidelines. I think in many ways, it's giving an excuse to the government to say, we're trying, but we are not able to deal, we are not able to implement it to the dot, so we are not implementing it. I feel that it would be better to have a more rational to why you would be putting people in quarantine, and ensure that then you do have enough facilities that you can put that many people in quarantine. And I mean, it's always difficult to take decisions on those questions because, initially we were told, no, there is no transmission through air, it's only through droplets. Then it became micro droplets. So all of these are also calls that have implications. And of course, for me, for instance, I feel very uncomfortable to say, no, this way or that way, because I'm just not a doctor. And you take a group of 10 doctors to take these decisions. But if a more stringent guideline means that there is no implementation of the guideline, what we need is guidelines that, have a scientific base, and more than anything, a way that we can have control on the government, or a way that we can report to the government when it's not followed, and that there is an action taken by the government in those cases.
All right. So the final question is, now currently our spread is mostly on the urban area. So what we are talking about is the large hospitals and, those kinds of facilities that we have. The moment, the pandemic, if, unfortunately it is expanding to the rural areas, how the health workforce in the rural areas specifically, you told about ASHAs, 9 lakh ASHAs across the country, but there are, are our rural facilities equipped to protect the health workforce in the way it should be? Or are we going to look at a tragical situation like many other countries are seeing? How would you see in terms of, safety and security of health workers if things are going towards rural areas?
So, I mean, I think clearly without an explosion in cases, our cities are already facing trouble. There are no more ICUs in Mumbai. The rural areas are, of course, much less, having much less availability of the kind of facilities that are required. And what we're talking about is that, I mean, when you get COVID and you are low symptoms, take care of yourself, stay at home. The issue, one of the issues is, what do we do with the people who get more severe and need hospitalization? There is I think one of the things that we might face is social discontent, and unfortunately directed at the health workers instead of being directed to the government. And I think we already see that a bit, but because the situation in rural areas will be probably more stark in terms of the complete inability of the health system to respond to the situation, that might also become more problematic. We know that in public hospitals, or not just in any hospital, when patients feel that there is when the patients feel that the system was not able to take care of them, they direct that anger to the doctor or to the nurse that is there, and those create those situations where patients and families are violent towards doctors and people that they see in front of them. The ASHAs could be the recipients of that kind of anger in rural areas, and that's probably a huge problem that could emerge. So that is something that I think is very problematic. Now, ASHAs, I don't think there will be a situation where ASHAs end up treating patients. Hopefully, they will continue being a link, give the information, and then you have, there needs to be a way that the patient can be brought to the hospital. What will happen with the symptomatic cases that are not critical, but where you cannot have a quarantine? These are also issues that are going to come up and create a very complicated situation. I'm not sure how that will pan out in terms of the impacts it will have on health workers themselves. In the rural areas, there's really going to be a question of the health system being really overburdened, and their social discontent being addressed to health workers. Yeah.
So now we have two, questions left. One is about waste disposal from the quarantine facilities. Who does and what are the issues there? And the second question was about, it's a general question which is coming from the information pandemic, what to do with currency notes, vegetables and all that. If you want to pick up that question. And then what is the maximum time for an N95 mask or other masks when the health workers are using it? So these are the questions remaining. And after that questions, I think we can close the discussion for the day.
Can you repeat what is the first question?
The first question is about, in the quarantine facilities, who are handling the waste and, what are the issues there? Specifically, it's about sanitation workers again. And the second question is about this life of N95 mask. And third one is somewhat general about handling currencies, vegetables and all that, what all are the risks there. But it's not necessarily related to the health workers. But that's up to you how you want to take or what don't want to.
I think the issues that we have in the quarantine facilities are also related to how do you organize the space and the workflow, and depending on the facilities that are chosen, it can be, so I think what I'm trying to say is that there is an element of ensuring that you don't just take, oh, we have this space available, so let's make a quarantine facility here. Or we have this hospital that's available, let's make a COVID hospital here. There is really a question of how you think the organization of your flow of work in a normal hospital, in a COVID hospital, in an isolation ward, or in a quarantine, that is the most adapted to ensuring that the different healthcare workers that work in that have the most secure working conditions. So there should be, for instance, only one door through which new patients come in, and a limited amount of non-medical health workers which are in that area with a certain level of protection. But then those that have been identified, and preferably that should be outside. So if you have, before you enter the hospital, a space outside where you can have the first screening, that is for the health workers actually the best situation, because we know that the physical distancing works much better when you are in the open air than when you are inside a building. So there, for instance, just doing that, you create a situation where there is a certain attention to how that infection can spread among health workers or not. And then you can have, so from this first step that is outside the hospital, it gets into the hospital, and there can be turns or ways that, for instance, the waste is managed that ensures that the life of the virus is taken into account. And if you ensure that you have your system of waste disposal with a certain logic, there should actually not even be a need for your sanitation workers to have more than the usual. They should have gloves because they should always have gloves. They should have a simple mask because it would be better that they always have a simple mask. So, and this is true not only for quarantine hospitals, this is true for each hospital's organization. And, I think probably the place where there is a more hidden risk is in the normal hospitals. Because in isolation wards, in quarantine, you have a sense that you have to take care of things. So it's on people's minds. But in normal hospitals, and that's what we have seen, people are just doing their work as usual. And doing your work as usual puts you at risk of infection. So we should really apply our mind much more to how do we organize our hospitals and organize them keeping in mind the whole workforce that we have in there.
Thank you. Thank you very much, Susanna, for your wonderful talk. Actually, you talked about the avalanche of issues, if I borrow your words. Avalanche of issues being faced by the medical staff in the country. And it's good that we got several questions. Since your speech has taken in a very good way, we got plenty of questions too, though we could not take everything to your notice. But it was a good talk, and thank you, Raman, for supplementing or giving a good finishing touches by compiling all these questions, and it gave added value to the memorable speech. And I think this COVID time has done some benefit to the society, because these issues of the workforce, health, I mean, especially in the health sector, were not discussing in the proper way it should be. And today, the governments, all the governments are taking the issues of the healthcare workers, the healthcare staff, that particular healthcare army in a better way. I think in the future time also, the governments will take proper attention, and the safety, security, and welfare of the this particular section of the staff will improve. With that note, I will like to end this session, and thank you very much, Susanna, for giving us time. And also, tomorrow again, we will meet with another subject. Tomorrow we'll be discussing about the workers, the laborers who are working in the essential sectors of the society in the country. And Mrs. A.R. Sindhu will be addressing, and she will be talking about that particular issue tomorrow at 7:30. So we'll meet again tomorrow 7:30. Till then, good night and goodbye. Thank you all.
Yes.
Thank you.